Historically, health insurance has been one of the most important drivers in the healthcare industry, and therefore the focus of many reform efforts. In this program, Dr. Gerald Kaminsky discusses the main sources of health insurance for Americans. Dr. Peter Bielenson then describes an innovative program that was launched in 2008 to offer uninsured residents affordable access to health care in Howard County, Maryland. Although not an insurance-based program, this public-private partnership serves as an example that may inform debate on healthcare reform.
Probably the single largest financial risk that we face as individuals is being hospitalized. It's by far the most expensive component of healthcare, and without insurance, it potentially is financially devastating for anybody to be hospitalized and have to pay the full cost of that hospital bill on their own. So insurance is a mechanism for pooling risk across a large group of individuals. It provides financial benefit to us because it protects us from bearing the risk of those adverse events on our own. And by making small payments in terms of premiums, we protect ourselves against the possibility of a huge financial loss should we require healthcare services. There's a long history of efforts to develop a system of national insurance in the United States. And at various points in U.S. history, those efforts to enact national health insurance programs have always been defeated because of a distrust of government intervention into this market. So as a result, private markets and private insurance evolved in place of government programs and government intervention in this market. Our current system of healthcare insurance in the United States is largely based on employment-based insurance. Most Americans receive their health insurance through their place of employment. This reliance on the private market and employment-based insurance is something that dates back to the mid-1940s. Because private insurance and employment-based insurance doesn't cover all Americans, as a result, we've seen the growth of social insurance or public insurance programs in the United States. So we have the Medicare program for the elderly and disabled, which was enacted in 1965. We have the Medicaid program for low-income families that was enacted in 1965. And we have children's health insurance, which was enacted in 1995. These are all government programs that are designed to cover people who would not be otherwise covered through employment-based insurance. So what we've seen is a system that's largely private with the growth of government programs to fill in the sort of the cracks or to fill in the places where the private market doesn't function well. And as a result, in the U.S., we currently have a system that's roughly 50-50 public versus private finance. The situation that existed before Medicare was enacted is that when most Americans retired from their place of employment, they no longer were eligible for health insurance. The Medicare program was designed to address this inequality in access to health insurance and to provide support for all American seniors to have adequate health care coverage after retirement. Medicare has been a very successful program, but it faces a serious financial challenges over the next 2 decades, largely as a result of the retirement of the baby boom generation. We're in a situation where we're living longer today than we were when the program was enacted in 1965, and we also have far fewer workers to support each retiree than we did when the program was enacted in 1965. Employers are less likely to offer health insurance benefits because of affordability. Workers and employees are less likely to take up health insurance benefits that are offered at work because the costs are substantially higher than they used to be. And as a result, there's a greater reliance on public insurance programs. We've also seen an increase in the individual insurance market. That is the market where people go and buy insurance on their own if they're not part of an employer group. That part of the market is not only growing rapidly, but it's growing with insurance products like high deductible health plans that provide lesser or a less comprehensive benefit package and much higher out-of-pocket payment requirements on the part of individuals, including very high deductibles. So this is insurance that requires a lot of out-of-pocket spending before your insurance benefits kick in. And as a result, there's a growing sense that many Americans are, although they have insurance, that they're underinsured because their insurance does not kick in until they've already spent a considerable amount out of pocket.
It's unconscionable that in the wealthiest, most technologically advanced country in the world, close to 50 million of our fellow Americans do not have health coverage. And probably 70 to 80 million additional Americans have such poor coverage they can't afford primary preventive care. So in Howard County, Maryland, which is located between Baltimore and Washington, a suburban county, the county executive and I decided that we were going to stop just talking about it and do something about it. So we've instituted the first of its kind program in the country by a local government called the Healthy Howard Access Plan, which provides comprehensive, affordable health coverage to the previously uninsured of Howard County. Put it in a little perspective, there are about 15,000 uninsured 19 to 64-year-old adults in Howard County. That's our universe that we're trying to serve. 65 and older are eligible for Medicare, and they're almost automatically enrolled. 18 and younger are eligible for Medicaid or CHIP, the Children's Health Insurance Program. So if we find a young person who is not insured, we enroll them in existing programs. The problem in the United States, and the huge gap in coverage, is for those 19 to 64-year-olds, the vast majority of whom, not just in Howard County or the state of Maryland, but around the country, well over 80%, are working people or members of working families. In the United States of America, the uninsured are predominantly working class and working middle class people, mainly those who work for small businesses that don't provide any affordable health coverage. The poorest of the poor get coverage. Those who work for large companies or who are wealthy get coverage, but the working class, particularly in small businesses, do not. That's what we're trying to address with the Healthy Howard Access Plan. So the plan is based on the premise that healthcare is a basic human right, but also a responsibility on the part of the individual. The individual who's a participant in Healthy Howard gets the following services. Primary care with their own primary care doc, for annual exams, for sick checks, for diabetic foot checks, whatever. The hospital in the county has agreed to forgive debt and not bill our patients for hospital emergency room services. We have gotten 17 different types of specialty groups, from cardiology to oncology to gastroenterology, GI docs, radiologists, etc., both inpatient and outpatient, to give pro bono services to our members. Fourth, we're getting prescription drugs either free or at 70 to 80% discounts for our participants. And the fifth component relates again to this rights and responsibilities. Healthcare is a right, but also a behavioral responsibility. So everyone in our program, healthy or not healthy, gets a personal health coach who, in concert with their primary care doc and the patient, develops a health action plan that they must substantively follow, or else they lose some of the services that I've just defined. Let me give you an example of a health action plan. You might have someone who's 48, like myself, who runs all the time, doesn't really have any major problems. My health coach might meet with me face-to-face once or twice a year and talk about nutrition. A much more common case would be someone like a 50-year-old diabetic, overweight fellow who has cholesterol problems but doesn't yet have the major consequences of chronic diabetes, but is clearly at risk for high cost for a high-end user down the road. His health action plan would include nutrition classes, quarterly visits to the doctor to have their feet checked for diabetic abscesses, make sure their sugar is at least modestly well controlled, and exercise 3 days a week, an hour a day. Our health coaches hold the participants accountable. Most of our program is tied together by electronic records. Our Healthy Howard Access Plan was initiated in October 1st of 2008. We're the only place in the country that has all these aspects: primary care, hospital emergency room care, prescription drugs, specialty care, and very importantly, this health and wellness, personalized health and wellness action plan with a health coach that has been done anywhere in the country. Funding for the program, from a political standpoint, was important, how we decided to fund it. We did not want it solely governmentally funded. We actually have a three-part funding stream, and it relates to our whole philosophy behind the program of healthcare being a right but also a responsibility. One of the contributors the pro bono, the hospital providing pro bono services, specialists, and we're getting basically mostly free medications. So those are the three biggest drivers of healthcare costs. We've gotten most of that pro bono. So that's one contributor. Secondly, the county government. Although we're a wealthy county, we only put in 5/100ths of 1% of our budget. So that level can be done by virtually any county, but it is at least some governmental support. Third, we've gotten foundation support. And fourth, very importantly, are individual participant fees. In fact, the individual participant fees cover somewhere between 60 and 65% of the actual cost to our program. Well, our goal is twofold. One, we are the Howard County government, and so it's imperative that we do what we can for our constituents, and the uninsured constituents who are not getting coverage through the state or the federal government should at least get some help from our standpoint, and that's what we're doing. Our broader mission, our broader hope is that we'll actually impact national health care reform by showing that a comprehensive array of services that we have in our program, with an evaluation to show that it works, will impact and hopefully be replicated at the national level, or at least at the state level. Honestly, I don't think it's the role or responsibility of a county government to provide health insurance. You don't want, there are about 3,500 counties in the United States of America, and you don't want 3,500 different programs, each funded at different levels with cross-border issues, et cetera. This is, at its root, a national issue.